Ladies and gentlemen, friends, colleagues, welcome back. Thank you for being prompt. I hope you enjoyed your lunch, and welcome to those of you joining us online. I hope you also enjoyed your lunch, whatever you had a chance to eat. So this session, after the lunch break, is going to tackle the issue of inequalities for childhood and adolescent cancer survivors. Now, we heard a lot about some of the challenges, and we heard about different inequalities. It just touched on, but in this session we're going to go in depth. And I'm delighted to say that this session is co-organized with the World Health Organization, the regional office for Europe in Copenhagen. And so I'm going to pass the floor to introduce it to Nino Berzulli, who is joining us remotely from Copenhagen. Nino, you're welcome. The floor is yours. Yes, we can hear you. Go ahead.
Thank you so much. Good afternoon and warm greetings to everyone, especially to young cancer survivors. I am Nino Berzulli, Director of the Division of Country Health Programs in the WHO Regional Office for Europe in Copenhagen. I'm very sorry that I cannot join you in person today, as this topic is very close to my heart. I'm a cancer survivor myself, and I stand with you. I applaud the European Commission for this initiative and for elevating the voice of cancer patients in our region. And I assure you that WHO is committed to supporting this effort. And I thank WHO Cancer Ambassador, also Aaron Anderson, for being with us today and his commitments to end cancer we know. Despite governments' attempts, the health inequalities between and within the countries across the European region remains unacceptably large, with potential negative consequences for social cohesion, the economic development, and individual outcomes. Achieving greater equity in health and reducing health inequalities is a key priority for the Regional Office for Europe. 1 year ago, we published the first studies on inequalities in childhood cancer. And what we found was that while some countries across the region have made important progress in expanding access and advancing the innovations in treatment, improving the way that cancer care is provided, children with cancer continue to experience differences in terms of rates of undiagnosed cases, access to high-quality diagnostic services, and cancer medicines and innovations, and ultimately outcomes depending on where they live and the circumstances in which they grow up. The childhood cancer diagnosis can itself be a driver of significant short and long-term inequalities, and we've heard today from the speakers on that. And these inequalities, the consequences are both for the survivors and the wider family. High-quality follow-up care that addresses the social and the socio-economic impacts of a childhood cancer diagnosis, as well as physical and psychological late effects, can make enormous difference to health and the well-being for these young people and their families. Unfortunately, for many children, treatment remains still either unavailable or unaffordable. For this reason, it is extremely important that we continue working hard together with our partners, with all of you, to reduce the gaps that still exist in relation to the care and the treatment of children with cancer across not only EU, but also across the entire WHO European region, which comprises the 53 member states. As part of the WHO Global Initiative for Childhood Cancer, we have continuously been bringing together stakeholders towards a shared goal of scaling up capacity to save the lives and reduce the suffering for children with cancer and reducing these inequalities that we know. The Regional Office for Europe stands ready to support the countries in the coming years as part of the joint efforts across the region to close the gaps for all childhood cancer patients across the continuum. This demands commitment, this demands the resources and the mechanism to ensure collaboration is meaningful and successful. Development of a network of childhood cancer survivors is a crucial initiative. We need to listen to patients to understand what is most important to childhood cancer patients and survivors. But we also need to listen to their families and the caregivers to identify the key priorities for reducing inequalities and to make sure that we are delivering exactly what their needs are. We need to understand cancer survivors not only and their needs not only during the treatment, but beyond. Mental and psychological and long-term support needs they require. The improvements can only be defined from the patient perspective. I would like to thank the panelists, everyone today who have joined to shed the light on this topic from different perspectives: survivorship, advocacy, policy, and the practice. And I look forward to hearing what you have to share and to what we can achieve together in the year ahead. Thank you so much.
Thank you very much to Nino for joining us and for sharing your experience. It's clear the passion that you have for the topic and is grounded in your personal experience as well as your professional space. And I'm delighted to introduce someone who'll join me here on stage, who's the WHO Euro person who'll be here in person for the co-organization, and that's Alison Ekberg. Alison, come and join me. Thank you. I'm now going to introduce all our panel, and they will come to join us on stage. And you know the process so far. We'll start with a patient experience. I have a question for each of the members of the panel, and then we turn it over to you. And we're looking forward to your questions. Those of you joining us online via Slido, those of you here in the room, we're going to throw you the microphone, and we need you to hold it close to your face so that we can hear it, but this will make it an interesting exchange. So let me introduce our fantastic panel. First, I have Victor Girbu, who's joining us, who is from Youth Cancer Europe. Welcome. Michele Calabro, the director of Eurega, which is the network of European regional and local health authorities. Welcome. Dr. Eleni Tolma from the Cancer Mission Board. Dr. Arman Kacharian from the Ministry of Health of Ukraine, the Deputy Director for the Department of Specialized Medical Care and Innovation. Thank you. Professor Katrin Scheinemann, who is from a CEOP board member, and there's a poster there about CEOP, and you're also the chair of PanCare. And finally, Ulrika Storast from DG Education, Youth, Sport and Culture from the European Commission. So welcome to this fantastic panel. Gentlemen, if I could ask for a little bit of space, I can join you. Thank you. We have, as you can see, a very full panel here to explore inequality in healthcare and exists across Europe. We heard that from Nino across the WHO region. And within healthcare, these inequalities could be specific challenges also for ethnic minorities or other population groups that are even more marginalized than the majority population. And the report that we've heard about from WHO... Thank you. So I was saying that the inequalities might be difficulties in getting access to equipment, medication, support services. It might be the distance you have to travel to get care or access to medical trials or well-trained medical staff. So there's a whole range of different inequalities. And We've also heard about the difficulties of educational professional opportunities. So we have a big panel and a tough series of issues to deal with. So we're going to start, as always, with a patient, and that means I'm going to pass the microphone to Victor to share the experience. Can you give us some perspective from youth cancer patients? What are the kinds of inequalities that you've heard about or that are coming from your network?
Yes, so I'll try not to be too harsh, but there's things I have to say because that's why we gathered here. Cancer patients face numerous inequalities. Some of these inequalities include, for example, late diagnosis. IAs often present with more advanced diseases as they are not perceived as being at risk for cancer, for example, and they are not routinely screened. Lack of age-specific treatment options because they are not often treated with either pediatric or adult protocols, which do not take into account the unique biological development and psychosocial characteristic of this age group. Inadequate psychological support as they increased psychosocial and emotional stress as they navigate cancer and the transition to adulthood, which is really important. These are several factors that contribute to these. There are several factors that contribute to these inequalities, including a lack of research and access to innovative therapies, clinical trials, medicines, and supportive services such as fertility preservation and mental health. In some areas, such as Eastern Europe, IA cancer patients face even more obstacles and disparities in access to quality care and resources compared to Western Europe. This includes a lack of financial aid for housing support and a higher prevalence of financial discrimination, for example, which can make it even harder for IA cancer patients to receive the care they need. Moreover, it's really important to mention that cancer survivors from the LGBTQ community face additional obstacles, including a lack of access to adoption rights, which can make it difficult for them to start families. In some countries, trans men with female organs might not even have the right to certain population-based free screening programs, further exacerbating the inequalities faced by LGBTQ IA cancer patients. For young people from Roma communities, the stigma and labels attached to their identity can also contribute to inequalities in access to healthcare. Youth Cancer Europe, for example, that I'm representing here today as well, is working to combat these inequalities by incorporating voices of young people from Eastern Europe and Central Eastern Europe and raising awareness about the challenges faced by refugee cancer patients. For example, I'm from Moldova. Yes, so that's Eastern Europe, for those that don't know. I had kidney cancer for 17 years. So I saw what it means for your zip code to decide your pathway as a cancer patient. So these collaborative opportunities, when IAs from Youth Cancer Europe and other organizations as well come together to really be heard, I think allow for things to go into the right directions and for things to happen for cancer patients and cancer survivors.
Thank you very much. I should say that Victor's intervention is incredibly impressive, given that we actually only asked him to be on the panel about 25 minutes ago, because he's stepping in. We had another youth cancer survivor who was going to be on the panel, but was feeling unwell. And what a fantastic sign of solidarity. You stepped up, and thank you for doing that at very short notice.
I'm honored. Thank you.
So let me turn to Michele, because we've just heard, your zip code, your postcode can determine what you'll have access to, which is both socially unjust and deeply inefficient. You represent a network of local and health regional authorities across Europe. Tell us a little bit about these big gaps between the lowest and highest performing regions. And do you have examples where you've been able to share the good practice and try and level up the other regions?
So, well, it's very hard to follow from after this very comprehensive presentation, which it well represents what we actually see with our members, regions, but also in general, also, through initiatives such as the European Cancer Organization Cancer Pulse initiative, which indeed it looks at the difference between countries even and the macro regions even that were already mentioned, in terms of so many categories, so many levels on which you can use to really identify where the inequalities are basically created from. And just to mention a few, I mean, there's of course, for instance, healthcare spending, which varies a lot between Western Europe, Central Eastern Europe, Northern Europe, Southern Europe. So that's one element where you can really, tangibly measure in a way how much countries are then spending and getting that early screening or even the care dimension. The availability then of medicines in the phase where once you enter, let's say, in the care process, how long it takes between the moment where something is approved to the moment it actually reaches individuals. That's another very important element that needs to be taken into consideration, and we're talking about differences of months. So it really changes how you can access timely care, which is not just about care. It's actually the right timely care for the right people. And then there are other elements that should also be always taken into consideration in terms of how organized countries are in terms of, and regions in terms of having dedicated cancer plan, for instance, because that helps to take into consideration all the different elements of providing right cancer care to everybody. And it goes, and this is also very important, to the availability of the right workforce. Because again, this is also something that, in particular in the year of skills, it's something that should be very much taken into consideration. It's about skills, but also it's about having just simply the right amount of oncologists, the right ones, also nurses that can take care of patients. So all these elements, these are just example of how actually there's a clear distinction between indeed the Western, Central Eastern Europe and the different parts of Europe, which it is something that, for instance, we as an organization are trying to work on with our members. And among the things that we do is sharing and discussing best practices. And actually something that I wanted to quickly share is one best practice, or let's say a group of best practice that comes from one of our regions, Regione Puglia, which is quite advanced in the way that they look at care, in particular for adolescents, survivors from cancer care. And I think in the work that they do, actually, they tackle some of the things that you mentioned. One element is the multidisciplinarity side. So really trying to look at the transition between childhood care and adult care. So really doing it through bringing together the different professionals that are involved in the process. So really trying to create these interdisciplinary teams and multidisciplinary teams that can really work together to avoid that they lose something in the process. Because if they don't talk to each other, it's going to probably happen. Providing them with the right training, it's a very peculiar type of care, type of transition then to life, basically. So it needs to be taken into consideration in a particular way. And through the training with this multidisciplinary team, it's something that they try to do. Last but not least, as part of the comprehensive activity that the region, to the hospitals is doing, it's also looking beyond the kind of traditional care, but really looking at how what they can do in terms of re-engaging young adults in musical activities, for instance, in sport. So giving all the possible tools to basically re-getting engaged in the right way, taking into consideration as much as possible their needs. Okay. It's just a best practice, but this is an example of something that we propose then to other members of our southern region, so they can say, hey, you know, this is actually working. Let's try to get it in our region as well. Little steps, it's hopefully helping.
Thank you. I mean, little steps make a journey, so it's you have to start somewhere. Catherine, let me bring you in because you represent a European network and in clinical experts. We just heard, obviously, you can't do anything about how much money is spent in different regions, but some of the things we've just heard about organizational practice, about the way that you do interdisciplinary, that is something that could be changed. What can you tell us about how your network tries to map out and address these kinds of inequalities?
So I'm a pediatric oncologist, so for me survivorship care is part of my daily practice. And PanCare is a network, so it's healthcare professionals, but also survivors as well as families. And we are closely working and have a long-standing relationship with SIOP-E, with CCI Europe, with Youth Cancer Europe. And just to have some practical examples, so it's like really how to improve care on an institutional level first, like really we can learn from each other, build it up to a national level. We start twinning programs. So how can a good example like really mentor a country or an institution which is starting to build up services? It's about education and training. So we do like annual meetings, but also from a training perspective. We did a 2-day workshop last year, which we like to repeat on like really young healthcare professionals to like really create interest in survivorship care and what it all needs to cover multi-professional, but also like to get like adult healthcare systems and physicians involved because we need them. We talked about transition before. It's about tools. So we talked about the SMART card, but at the end it's like how to write a treatment summary, how to translate this in follow-up. So it's about guidelines developments, living guidelines, because there is so much evidence going out that we really have to update them. So I think we can, as all the stakeholders, give a framework, but we really have to start on an institutional level. And my plea is out to all the survivors here as well as family. Please raise your voice and push us each day until we really make the progress at your institution, in your country, across Europe, until we have reached the goal.
Thank you. And before I move on, you said that you run these trainings, and obviously you're a pediatric oncologist. This is your day job. Do you see a sort of similar interest by other professions and other clinical expertise areas that cross the path of child and young cancer patients, but it isn't their 100% job? Are they also interested in understanding more about this big journey? How easy is it to get other people to come in and join these trainings?
So I think it's relatively easy in the pediatric world because everyone understands. And I mean, I have now like started at 2 different institutions in Switzerland, like really a survivorship clinic, including a transition clinic. So you have to go to your adult colleagues. You have to make them interested. You have to also show them it's the same whether someone is 16 at diagnosis or 19 or 21. So they benefit all, as normally if you say it's the age cut of 18. And there, you have to create a momentum, but I really think we as pediatric oncologists are in charge. We have to start it, otherwise it won't work.
Excellent, thank you. Oman, let me bring you in now, because a couple of our different panelists have said that one of the challenges is that childhood cancer is low visibility. It's not the high-risk category group that people think of when they think of cancer. So how do governments and stakeholders raise the profile and the awareness of childhood cancer? And is that the role of government? What can they do about it? How can they, play a role in addressing this?
Oh, okay, thank you. I'm honored to be here, and I've been working at the Ministry of Health of Ukraine for the last 4 years, so you can consider me as an experienced bureaucrat. So from my point of view, from my experience that I want to share with you, everything depends on patient society. I mean that I've noticed that patients and patient associations, they are the best, the strongest promoters of changes in healthcare area. It's honestly. And so I mean that you can everything. You can join, you can build networks, you can make contacts, and honestly, you know, personal connections, contacts, they work and they influence policy making. So I want to share my experience from about cooperation with some patient organization in Ukraine. We met during meeting like this one. I met Ukrainian doctor, I met Ukrainian non-governmental organization, and we decided, that was in 2018, we decided just to create a new specialty in Ukraine, like a pediatric hematologist oncologist. Because before we had two separated specialties, pediatric hematologist and pediatric oncologist. And that was a great problem, because like a pediatric oncologist, he used to treat only solid tumors, and pediatric hematologist used to treat only lymphomas and leukemias, and that, you know, patient should be referred from one doctor to another doctor to make some differentiation. And so we established, like, I met my colleagues, I met doctor, I met NGO, and we decided to change that thing. So NGO prepared special letter, doctor prepared letter from pediatric hematologist oncologist associations, and I'm from ministry. I prepared all necessary legislation and adopted that. So I mean, my point is if patient society wants to make childhood cancer visible, wants to change something, achieve some goals, you just should make contacts and team up, stay in touch. And with it, different conferences speak to, even in national level, it's very important to have some connections in national level also. But that conference where I met my colleagues from Ukrainian hospital and Ukrainian NGO, that was organized by international organization, WHO and St. Jude Research Hospital from the United States. So even outside of Ukraine, I met my colleagues and we organized, I would say, transformation core team in Ukraine. And now we have a strong pediatric hematologist oncologist society in Ukraine. And regarding your question about visibility, that was just my message to this amazing public, because I'm impressed to be here, honestly. And our government, alongside those professional associations, we put information we changed training programs for pediatricians first, and also for family doctors, and for pediatric recently adopted pediatric hematologist oncologist. But it's not enough, honestly, because put something into paper. It's one thing. It's not as difficult as someone maybe imagined, but we have to assure the quality that legislation should work, and that's where I presume patient societies should be active. They should follow those changes. They should control that, really, and they can maybe even engage somehow media, because media, they can make your voice 1,000 times louder, honestly. And that government usually relies on public opinion. And in Ukraine, we have a lot of examples where patient societies and professional associations built some networks, and through media, they changed legislation. For instance, we have a superhero school. That's now it's a governmental program, but that some NGO, some person, activist, she started to teach children in biggest Ukrainian pediatric hospital. And then she engaged national media to that program, and through national media, government was forced, I would say, adopt new legislation about that education in hospital during the treatment. And so my point that even if government puts something on paper, patients associations, organization supported by international organizations and some professional associations like CEPI. They should control that processes. And that can also, networks can save lives. For instance, when the war started in Ukraine, Ukraine NGO, through a network of professional associations, they evacuated almost all children with cancer to European countries and to Northern American countries. I mean, through CAPs, through professional associations, in 1 or 2 weeks, they evacuated in the first 2 weeks, they evacuated 250 children from Ukraine, you can imagine. And that was made through those connections. We didn't send, at that time, some official letter from government to other governments to prepare those evacuations. NGO and professional associations network did that so fast. Of course, you need government for sustainability. Government can be involved, should be involved later, and so it works slowly, but sustainable, I would say. So that's my point.
Thank you very much, Arman. That was a really inspiring story of change and how change happens and how you bring together the convergence of interests to actually make it happen. And thank you for, again, showing us where the energy and the impulse can come from the Patients Association. You have clinicians with an interest and a readiness to change, and governments who write the paperwork to make it happen, but it doesn't happen unless those other two stakeholders take it and make it live. Let me now turn to Eleni, and you of course sit on the Cancer Mission Board, and you've decided as part of that there's a focus on inequalities. So can you tell us a little bit more about what you're doing as a board to reach out and understand the experience of inequality for young cancer patients across Europe and their families?
Can you hear me?
Yes.
Yeah. So first of all, our presence here, it's an evidence that this is a very important issue for us, for the board. And I just want to reiterate what Amanda said earlier, that the board is fully committed to the cause of childhood cancer and survivors, and will do anything in our power, not just to listen to the patients and the survivors, but to strengthen their voice. In a lot of the workshops, we heard the proposed solutions, and how the NGOs are trying to bring change, but it's hard, especially to work at the local level. So one of our jobs is to help them break the deadlock and bring change, and not only at the European level, but also at the local level. Also, specifically what we can do, based on what I've heard in the workshops that I've been to, the two themes and in terms of inequalities is the lack of multidisciplinary approach to care in all the countries, and also the need for psychosocial support from the time of diagnosis and throughout life of the cancer survivor. So one way, and this is in line with one of the objectives of the Mission on Cancer, which is the creation of comprehensive and a network of comprehensive cancer infrastructures by 2025. And these are regional or local infrastructures that provide resources and services to support, improve, integrate cancer care, research, training of care professionals for cancer patients and survivors, with emphasis again on childhood cancer survivors. Another way we'll provide is another objective of the mission is support of quality of life of cancer patients survivors. And we're planning to design a monitoring program, a longitudinal monitoring program where we monitor the quality of life of the childhood cancer survivors. And obviously we invite the patient survivors to help us and develop the monitoring program. We're also going to be working with other entities. We're already working with other entities. I know WHO is, and I think she's going to talk about it more, about childhood cancer registries. And I think it's important that we work on promoting childhood cancer registries in every country, because one of the inequalities we found out is that we have underreporting of childhood cancer, and not in all of the countries, but it's important that we monitor and report who has cancer and create a database so we can actually do research locally and find out what are some of the factors that create cancer. The other thing I was gonna say is that we're also visible, try to be visible, all the board members in different conferences, initiatives like the European Cancer Imaging Initiative that took place recently, and we try to bring in the forefront, what does the initiative do for childhood cancer. And also, finally, we try to monitor the inequalities and propose opportunities for future research. And as a lot of the childhood cancer patients said, we need to focus on the real issues that the patient survivor face. And one of our jobs is to recommend, maybe call for research proposals in the future to address those issues.
Excellent, thank you. Ulrika, I'm going to bring you in now, and we're going to sort of zoom out a little bit from the specific issues of healthcare, because we heard a little bit earlier about the challenges for particularly young adults, or that they're in education, whether it's school education or university education, that gets interrupted for their treatment, and so they may have to drop out of their education. How can the learning and educational needs of young cancer patients be met? How do we improve the system to make sure that their healthcare needs are being balanced with some of these other equally as important developmental needs through the way that education is either provided or organized?
Yeah, thank you for the question. I hope my voice carries me through this intervention. I have a bit of a cold, but I think it's an very important issue, and I'm happy to share and also to listen to your experience, because our mission is really to make quality education as inclusive for all as possible, and it's very clear that long-term absence from schooling creates and reinforces a lot of the problems that you have described. So basically, it doesn't have only consequences on the learning, but also on the social inclusion and the social interaction. So basically, access to education is a fundamental right, and absence because of illness doesn't need to go hand in hand with absence from schooling. And this is, I think, what I want to give you one practical example, and then tell you a bit how we are working at the systemic level to make this also happen throughout Europe. So one example is how can the educational needs of young hospitalized children in particular, or those in the early stages of return to home but not yet able to go to the classroom in presence, how can this be met? And there I think technology has really made major advancements in the recent years. So for example, the telepresence robots, I think this is a good practice to highlight. Along with other maybe more accessible remote tools, video conferencing tools, etc. I think this is really important, and making it possible for children to stay connected with their teachers, but also with their classmates, and also basically it goes both ways. The classmates can also be connected with the young person themselves. There are even telepresence robots where you can gently strike the cheek of the robot and express your empathy and care for the classmate that actually has to stay at home or in the hospital. And there have been studies that have accompanied such technology, let's say transmitted education. And they basically, especially for example in Denmark, there's one telepresence robot that has been used quite widely in primary schools. That this really has some positive advantages, as I say, not only on education, but also on the social inclusion. But maybe some of you have more experience on this from firsthand, so I would be really, really interested to hear how you have experienced it. I can give you the state of research, but of course you have the real experience. In terms of how can this be brought to the system level, I think, to be honest, looking at the pandemic times, COVID has really shaken up the way that we think about school education. It has brought a lot of negative consequences, school closures, etc. And I think we are just starting to understand the long-term consequences on children and adolescents as a whole. but it brought also really to the forefront the capacity of innovation of individual teachers, of schools, of headmasters, and the need to really think about education in a different way. So basically, education doesn't take place only in the classroom between one teacher and the class, but it can take place in a lot of different environments. Sometimes from home, sometimes from the hospital, but it can take place in outdoors, etc., in museums. It can take place via, let's say, classical books and a blackboard, but also via via technology. And this is basically what was brought up also very much to the policy debate, and we made a proposal to really shed light on what we call blended learning. So it's really something different from this remote emergency teaching that was done during the COVID times, looking at the positive examples, and that I've given some of them, like the aspect of inclusiveness for children that are, for example, hospitalized, that can continue to access what is happening in the classroom. So we say we need to focus on this, what blends of learning are actually inclusive, which ones foster the quality. There are lots of good things that you can actually learn on yourself with videos online, but you need a teacher that actually knows how to embed this in the classroom. So all this, what we basically subsume under the topic of blended learning, was brought to the highest political level, and we have a council recommendation by the Ministers of Education from November 2021 on blended learning, and my job is actually to make this happening, to look at good practices, to look at practices that are inclusive, and to make sure that also teachers, that basically they have the access to the right professional learning opportunities to put this in practice. So just to summarize, there are good examples for individual level, but it also helps, I think it also helps to rethink the education system for everyone, to make it more inclusive.
Excellent, thank you very much. I'm going to take this moment to launch our Slido poll, because we'd like to get a sense from you in the audience, which are the key inequalities that you've experienced or that you're going to prioritize. So we're going to launch the Slido poll, and as people are voting, I'm going to invite Alison from WHO, who's co-organizing this particular session, to comment on that. And perhaps you'd like to refer to the childhood cancer inequalities work that you've done. So here's what we're asking you. We're saying, have you experienced any of these inequalities in your cancer experience? And again, we're focusing very much on the cancer patients and survivors in our community, because we want to hear your experience. And I'm afraid you have to scroll down a little bit when you look at it, because I think we've given you 5 options. But was it in treatment? Was it in care and pain management? Was it in survivorship, diagnostic periods, or rehabilitation? So we're trying to get your experience. And while you're voting on that, Alison, let me pass the floor to you to comment on why WHO Euro is really picking up on this issue.
Sure, thank you. Thank you very much. And again, I really appreciate the opportunity to be here, because it's been really very impressive experience the last 2 days, getting to know so many of the survivors in person and other people working here. And the Childhood Inequalities report, I think it's important because it looks at inequalities in many different ways. So inequalities within countries, across countries, and as well as childhood cancer as a driver of inequality. And I think what it also emphasizes is we have to take really a health systems approach, and any change will require all of us, and it often requires also looking outside of the cancer space. As we talk about some of the areas, really the health systems and the building blocks of health systems. So when we're looking at the need for data, because in order to really understand those inequalities and to see any change in them, we have to have better data. So it's about building the childhood cancer data registries. And then also from a health workforce standpoint, I think bringing in our, thinking about what are the core competencies we need to see across the care continuum, and then how do we develop frameworks so countries or regions can map those competencies to the positions that make the most sense. We also have to think about health financing, as we've heard, the impact of health financing on cancer care, so and education. So I think really it's just a reinforcement of the need for this collective effort, and especially the voices of survivors to help see, what needs to be addressed and to help prioritize. So I think it's been really important to hear your views and the importance of psychosocial support throughout the care pathway, beginning from diagnosis and checking in throughout. And that the message we heard also is that, it's not life after cancer, it's life with cancer. And how do we change systems? How do we adjust health systems to better meet the needs of cancer patients? So I think where WHO comes in often is from this health systems perspective, and helping countries in identifying the policies or the technical assistance that's needed, and also as a convener. So I think we really look forward to playing a role in this space going forward and to continuing to work with everyone here. So thank you.
Thank you very much. And I'm just now looking at the results of our poll, and coming out very well ahead of everything else. And we gave you, I think, a maximum of just 2 options, or possibly 3 out of this, so you couldn't choose all of them. Survivorship is coming out at the front, as well as the treatment period. Now, it's interesting, the survivorship, because that's the life after the intense period of treatment. And when we asked you the first panel, and I said, which were the 3 transitions that were the hardest, particularly from a mental health perspective, it was that transition, from oncology care into general health population care, which is, in a way, fully aligned with this, that it's the survivorship, the inequalities. Did you get access to your educational opportunities, economic opportunities? Did your families get support? Did you have the long-term care that you needed? So clearly this is an area that people are interested in exploring. I'm now going to open the floor, and you know the routine by now. If you're joining us online, you can use the Q&A section in Slido. Is there anyone here in the room that would like to contribute or make a point on this issue of inequalities, how it's experienced and how we address it? Yes, we have a hand up. We're going to give you the microphone. You need to make sure you hold it close to your face, please, in order to speak. And please introduce yourself. It will work if you start speaking. But hold it close to your face. I know it's counterintuitive, but if you hold it too far away, that's when we get the strange feedback. So if you hold it close, then it's easier for us to hear.
Should I put my lips on? No. Okay.
That's a little too close. In the post-pandemic world, no.
So my name is Gilles Vassal. I'm a pediatric oncologist from Gustave Roussy in France, and I'm here as IOP Europe board member. I would like just to make a comment on an important message delivered by Dr. Eleni Tolma. You highlighted one of the important objectives of the Cancer Mission and the European Cancer Plan in creating a network of comprehensive cancer centers that will provide high-quality care and research to 90% of cancer patients. This is a major initiative in Europe, but it will not work for children and adolescents with cancer. It is important that we keep in mind that the way we deliver care and research is through pediatric hospitals and some in comprehensive cancer centers, and never in private hospitals. So the way the care and research is delivered in Europe for children, adolescents, and more young adults is not through this comprehensive cancer center. And this is why at the moment we need to address how this care is delivered and what are the inequalities. And this is very important because at the moment, Europe is building the European Cancer Inequalities Registry. And last week, the country profile have been released, really showing all the inequalities across the different member states. But there is no information on childhood cancer yet. And this is where we need absolutely to generate this information across Europe. How care is delivered, how research is delivered. What are the inequalities? Because the message from John Ryan this morning was very important. This is also at the member state level that things can be addressed. And the way it can be addressed is by us, professionals, patients, survivors, working together and lobbying at the member state level, saying, well, you need to address the inequalities in your country, considering what's happening in Europe and showing what are maybe the way to provide equal access for all patients across Europe. So I think it's very important we all work together to look at these inequalities, including survivorship, and really tell not only European Commission, and really they are very committed, there are major measures in Europe, but also at the member state level. We need to work together at the member state level to move the lines for children and adolescents with cancer. Thank you.
Thank you very much. And Michele, in a minute, I'm going to invite you to respond about, at the local and regional level, do we have the data? Do we know, have we disaggregated our cancer registries for children, and therefore are they properly visible so that we can address this? And Eleni, maybe you could respond on this issue that, it may...
I totally agree with what he said.
Okay, please go ahead, yes.
Yeah, and you have to, our role as board, members of the board mission is two. One, we work at the European level, but also work with our member states. So our role is like a catalyst to try to implement the cancer plan that was developed by the previous board, but also we have to take in consideration the regional or the country cancer plans, because every country has its own, and try to make sure that, these comprehensive cancer centers are actually implemented in the states where we're working on. So I totally agree with you. It's a lot of coordination and working together.
Okay.
So the message you will be given to the board when we meet again.
Okay. Michele.
I can... Works?
Yes,
okay, it will.
The technical team is watching to see who's got the microphone. Takes them a second to respond. But
Perfect. No, I also agree, to be honest. And I think a network like Euriga and the regions that, of course, are delivering directly, they have to play a fundamental role. And I'd be very happy to, see what we can do also with our members to contribute eventually to these more local and regional collection of evidence, because indeed, like, if you do not map, if you don't have the data, it's also harder to provide the right response. So just to say, we do not have the data yet directly in our regions, but we'll be very happy to work on that. And I think one important element that came into the discussion, that it's also connected to the local and regional level. We talked about education, we talked about the importance of professionals. I think this is something that we're trying to work on with members, the concept of community. So, the survivor, the cancer patient, it's not sitting in a vacuum, especially the closest level. Often it's regional and local, even where maybe the country is organized in a slightly different way than, I don't know, Italy, for instance, where the care is heavily regionalized. So I think the point of providing that the survivorship support, the reintegration into the community, it has to be done through a creation of more coherent community. At that where that happens, it's maybe not at national level, but it really needs to go to the local and regional, and also with the very strong support of NGOs or patient organization, because that's, again, it's absolutely fundamental at all levels.
Katrin, I wonder if I could invite you to come in on this, because my understanding is that one of the challenges of cancer registries, and they're very different in different countries, is it's a sort of snapshot of time. It tells you how many people have had a cancer diagnosis, but we don't have enough about, or not all registries track progression, outcomes. And when we're talking about children who've had cancer, or young people who've had cancer, and we want to know about late effects, that's come up several times, we need long-term tracking, and that needs to be traceable. And you work as pediatric oncologist, so there's in a way a cutoff point for you as well on the sort of data that you collect and you deal with it. How are the professionals looking at this to make sure that the sort of data tracking and monitoring is following young cancer survivors and is then going somewhere, it contributes either into the cancer registry or something else, so that we can move from a snapshot in time of how many people have got cancer to understanding the evolution, and therefore see there's inequalities, there's challenges.
So I can maybe give two different examples for this. So within our treatment protocols, we collect a lot of this data, not during treatment, but also follow-up, so 5 or 10 years thereafter. And then we are trying to implement like really longer follow-up registries. In Switzerland, I know we're not part of the European Union. We have done a different way. So we have a childhood cancer registry since almost 50 years. And we have decided really early not to collect only data on like really the cancer type and the acute treatment, but really long-term follow-up. So they are consenting really lifelong. And now since 2020, we have also a registration law. So it's not only us in pediatric oncology who have to do that, then also if they are reaching adulthood and are taken care by adult physicians, they still have to do this. So we are collecting a lot of additional data, but that's maybe something for a relatively small country with a small number, because it's a lot of work, but it's really important. We need this long-term results, or similar like St. Jude's, one of the biggest hospital, has really a lifetime cohort, and there we have learned from survivors who are now 60, 70, or 80, like what are their problems, like really then when they're 50, 60, 80, because then like you're aging, there comes the normal, I would say, the cardiovascular diseases, etc. But still, what is the influence of the childhood cancer and the treatment?
Thank you. Armand, maybe I could bring you in on this, because you've given us really interesting examples of how radically you changed, practice, but it's quite recent. So how do you embed this over time? How do you make sure that the movement that brought together the patients, the sort of oncologists, and the ministry in this sort of focus to get things right, that then becomes a living process and you maintain the data in the registry over time and it can be expanded in this way?
Yeah, it's essential to have a proper cancer registry in your country. We have a cancer register of Ukraine. The data collection, the quality of data is not good enough, of course, but what I mean, I want to tell you that changes, I can't call them radical, because radically we transformed our healthcare system in 2020. We drastically changed financing of Ukrainian healthcare system. We had that Soviet system. We paid for beds in hospital. Honestly, they're a hospital and they have 100 beds, we should pay for 100 beds. And now we're paying for patients treated. Some hospital with 100 beds, if they treated only 10 patients, they will get money for 10 patients, and opposite. Cancer registry, there is a problem with cancer registry in Ukraine, obviously, because we also digitalized, we make our medical records, medical electronic system only in 2020. Shame on us, of course, because before 2020, doctors used to send some papers, to different to cancer registry and collect those papers, and you can imagine quality of that data. And regarding childhood cancer, I know that some of our hospitals they contribute to St. Jude pediatric cancer registry, and I came here to Brussels cashless. Honestly, I came from Ukraine by train, in Poland by bus to the airport, from airport by plane, cashless. I mean, I have everything in my phone, in my Apple Wallet. I have all my Ukrainian, at least, documents also in my phone. In European Union, I still need to use my paper passport. So I hope one day we'll change that things also. I mean, today we can collect through the phones patient-reported outcomes. I mean, we can make those inequalities, those data about inequality more evidence-based. I mean, collect through your phones different information about treatment, rehabilitation, and other healthcare services. And also, I presume there should be in Europe, and I hope we will join to European Union, and we will contribute also to that registry, one big registry for pediatric cancer, because it's easier to establish proper registry for pediatric cancer than for adult cancer patients. In Ukraine, for instance, we have almost 1,000 new cases per year, pediatric cancer, childhood cancer, and 140,000 adult cancer. So you can imagine that data for 140,000 patients and 1,000 patients. So, and I mean that we can precisely collect those information for pediatric cancer registries, and that will allow us to see what is difference, what is difference between excellence centers and just oncology department in some regional hospitals. We can collect patient-reported outcomes from patients directly, and we can know what is going on in fields. And regarding, Excellence Center, because that was an interesting question also, because we are moving to that in Ukraine. We want to establish few Excellence Center and treat there 90% of all diseases, cancer patients. Because there is a problem, we have 30 cancer departments for pediatric departments in Ukraine, and some of them treat less than 30 new cases per year, you can imagine. So we want to concentrate, but there should be a balance. Ukraine, a big country, and like some patients, there we could create inequality, creating Excellence Center, because some of them patients, they want to have department, cancer oncological department near their houses. It's understandable, of course. It's inconvenient to travel through the whole country to Kiev or to another big city in Ukraine. So, I mean, it's also challenging, but electronic data, it's essential for policy making and, quality assurance. Because without this electronic, in Ukraine, we established different things, we implemented different policies, but there is a problem. We can't assure quality, and we can assess the results of that policies because we don't have a qualified good data yet, of course, because we started in 2020. Thank you.
Thank you. I've got a couple of hands up in the audience, so can we have the thrown microphone? We have a lady here, and then we have two speakers there. Maybe we could start here at the front, and then I've got two gentlemen there. And I just want to acknowledge that Rita put us a message. It's not a question, but she just wants to acknowledge that the voice of the childhood cancer survivors is very powerful. And I think we would all agree that it's been very strong in this meeting. Please go ahead.
Thank you. Thank you so much. I'm Katie Rizvi from Youth Cancer Europe. And there are two comments I would like to make. This session is about equality, right? But what I'm hearing mostly about is equality in geopolitical terms, as in East and West divide, or age-specific. That something that Youth Cancer Europe is advocating for is how young people and children with cancer have less opportunities, less research done for them, less access, and then poorer quality of life later on. However, I believe that the European Commission only focusing on these two dimensions is very archaic and does not consider a lot of other things that are important for considering equality. And this is something that Victor actually has mentioned. We do need to pay more attention and look for data and do research and generate evidence so that we understand more about the experiences of young people with cancer with the intersectionality of discrimination because of race, ethnic minorities, gender, sexual orientation, socioeconomic status, etc., and we do not have data. And so this is one point, which I really believe that the Commission and the Mission Cancer Board needs to listen to young people's input on this. And the second one is a very quick point on the Ukraine crisis and the very important lessons that you have shared from Ukraine. Youth Cancer Europe was involved not in the evacuation of children, but in the evacuation of adults. To this date, we have helped more than 300 Ukrainian cancer patients access continued therapy in 18 European countries. Now, a case example is that in 1 week, we were able to mobilize and help with translations of medical documents, insert and send to these different hospitals or find locally interpreters. We had language support volunteers in 1 week from the beginning of the crisis. Youth Cancer Europe started its operations on the 25th of February, and within 1 week, we had 15 local language speaker volunteers helping us in 18 countries. So that's huge. Yet, to this day, ethnic minorities and language minorities in many European countries and migrant populations do not have translators, do not have documentation, information, leaflets available in their own language. So we know we can do it. We just need to pay better attention, and I think we need to do a better job in actually describing and defining what inequalities mean in Europe today for cancer patients.
Thank you very much. Yeah, please go ahead.
I'd like to circle back on a topic that was mentioned before, which is the digital participation for children and adolescents who may not be able to go to school or university. I myself wasn't able to go to school during my last chemotherapy and after brain surgery, so I was very fortunate to be able to use a robot from the company No Isolation. It's called AV1, and it was really great to use it. You can use it with an app, and you can turn the head and the head lights up if you want to say something. It was great, really. But the point I want to make is that the General Data Protection Regulation can be used in a way so that children can't use this robot, because if one child in the classroom, or rather the parents of the child, say that they don't want this robot, the robot doesn't happen. And this is really a make or break situation, because for me it was a fortune that everyone in the classroom, after heavily discussion with my parents, said that they were okay with it. But for children who are not that fortunate, it might be the case that they can't use the robot and that they can't attend classes even digitally, and they will miss school, and it will have a huge effect on their academic career, but also on their physical health. And so I would like to ask you, as people who are in power, to maybe think about how this can be avoided, or this trap can be avoided for children who are already suffering from enough problems.
Thank you.
Again from Lithuania.
Hold it close to your mouth, that's it, yeah.
Sharunas again from Lithuania. I first wanted to welcome the Ukrainian public official. I really am thinking if we would have such proactive guys in my country, we would achieve much more. So thank you for making effort and really explaining to me, if Ukraine managed to do that, then there's no excuse for the rest of us not to do it. Two comments again on inequality. One thing about the comment that you want to receive treatment closest to your home, which is universally true. However, when you are facing life-threatening condition or a rare disease, what politicians often escape is you don't think about being treated closer. You want to be treated at the best center. So that goes out of the equation. And I often still see in the Commission communication that the distances is important, but with European reference networks, you've shown that it's possible. So one plea in that area would be, you said we have European reference networks for pediatric cancers, we have one for rare blood cancers, we have for rare solid cancers, but we know about this 300,000 young cancer survivors. Maybe we need an ERN for this part of the age population, because majority of these patients do not have access to the treatment at home. They need to access cross-border healthcare. Why? Because most of the time, yes, you could get some type of therapy, but it would not be the best therapy for your particular event. And we have a lot of cases from our community where patients had to travel to different countries, not just once, but multiple times. And this is accessing cross-border healthcare, and that's if your treating physician or the department is not aware of that, you don't have a chance, because it's very slim chance that you would get that information when going online. It's a slim chance that you would get a useful information from your government if you ask that. So then it goes back if your healthcare professionals are aware of it and if they are willing to help of translation documents, etc. That was first comment. Second comment on the inequalities is a bit of relating to the disabilities and discrimination. So here, when we are speaking in this context about what are other inequalities for the young cancer survivors, we need to think that the community about the disabilities have done a lot legislative-wise, that European-wide, we have national laws that say you cannot be discriminated on the grounds of disability. Now, the problem in a number of states, including in Lithuania, where I'm from, is the moment when you are considered disabled. So in my country, if you are on an active therapy, you cannot be a disabled person because it says disability is what is left after you finish your therapy. So, you know, if there is an instance and you lose your limb, then yes, it won't grow back, you are disabled. But if you are continuing a therapy, and it may last, you know, for many years, that means you are effectively being considered survivor, but because you are still taking pills or whatever, you cannot get access to the disability status. That means you don't have a legal protection against that. What means in a young cancer patients, you are not in that part of quota that if you are enrolling in university, there are people, you know, quotas for disabled people. That means you are not protected for being fired at work after hearing that you have cancer, because you could not fire the person because of his disability. But if a person is a young cancer survivor being diagnosed, being under chemo, doesn't have disability status, what's the best thing for the employer to do? To fire that person as soon as possible, because later on it will be more difficult. So this is where actually I think the union level action could be. And because discrimination, backgrounds for discrimination, we are not describing it properly. And when we have this access as European citizens to a high-quality healthcare, what does it mean specifically? Is it not to be discriminated on a gene condition, not to be discriminated on a gender? We have those terms, but we don't put context into it. And I gave you context where that is escaping the loophole. And it is becoming more of an issue when we look into survivorship. Because the numbers will grow of the survivors, so these issues will grow as well.
Thank you very much. We don't have long left in this panel, and I get the sense we've opened lots of conversations that need to be continued in the next panel, where we're going to be looking at where the research priority should be, and you've identified lots of gaps. And thank you for highlighting the issue of intersectionality, and that disability comes in many different grades and many different forms. And I think we'll carry that issue into the next panel, because I think it needs to be dealt with. Does anyone from the panel want to respond to areas around, how the GDPR, does or doesn't serve patients, and also, looking at this, I don't know if it's within the remit of the Cancer Board or not yet, but this very interesting issue that's been opened up around there are legal frameworks that protect people with disabilities, but how do you classify it? Where do children or young people going through cancer treatments, where do they sit in that? It's a very interesting, very detailed issue that needs to be explored, where the existing levels of protection are sufficient and where you're falling through the gaps. So Eleni, would you like to comment on, is this a new issue that needs to be addressed, or has it already been touched upon?
I think it's something we're going to be looking into. It hasn't come up in the conversations that I had, so definitely we need to look at the legal framework and how the childhood cancer patients are seen from a legal perspective, like as a disability, like the person said. So definitely we'll look into that.
Thank you. Alison, you're the co-host of this event, and I don't know if you want to comment on this point about intersectionality, because this is really uncomfortable territory for many governments and cultural institutions, but it's clearly an area that's been brought forward by the cancer patients themselves, but you've mapped out the existing inequalities. To what extent has that allowed you to surface some of these issues that have come forward, like race, like gender, like sexual orientation? Or is that still too much of a politically hot potato to be addressed?
No, I will say that, as I mentioned earlier, that the study does look at inequalities, as I was mentioning, within countries. So that means within countries, looking at the inequalities across different populations, vulnerable populations, and vulnerable for different reasons. Yes, is more data needed? Always. So I think, that's why we divide the report into inequalities within countries, across countries, and as, cancer as a driver. So can more be done? Yes. And I think this was the first study of its kind in WHO. The European region was the first to do this. So I think it's a starting point to open that conversation and think about where we need to dig to understand better and where we need to collect more information. So.
Thank you. Victor, I'm going to come to you because I promised that each session would start and would finish with the voice of the patients. In the beginning, you set out for us a huge range of different inequalities experienced and identified by young cancer patients, and that's been echoed by some of the members of the audience. But what's the last message you'd like us to leave with? As we've said, this is the first time the WHO globally have done something, and it's led by the European region to map these things out. We've heard from the Commission that it's a beginning of an engagement and a real direct process. What do you hope that the sort of young cancer patients would get out of these first steps in a journey?
Well, and not only young cancer patients and cancer survivors, but everyone. Just look at the results. The results are really speaking for themselves. Survivorship. Cancer is no longer a death sentence. There is life, and we need to make sure that this life after cancer is as good as possible for everyone. So if there is one thing that everyone needs to go home with, is thinking about how to make the life of cancer survivors better and better and better.
Excellent. So can we say a warm thank you to our panel for engaging in this topic? And thank you to Alison and to Nino from the WHO for co-convening and organizing this session on such an interesting topic. We're now going to take a short break. For those of you here, we're offering you coffee at the back of the room. For those of you watching online, we will start again at 2:45. So we have 15 minutes to refresh ourselves, use the bathrooms, and be seated again for the final session on research. So thank you, and see you in a bit.